Hello people, in this video we want to look at this topic Hyper Emesis Gravidarum. We are in Obstetrics. So people under vomiting in pregnancy, there can be early pregnancy vomiting, late pregnancy vomiting. Early pregnancy vomiting can be a simple vomiting, which is also called as morning sickness, or emesis gravidarum, because emesis is the word that you use for vomiting, right? Emesis is vomit, and gravidarum refers to pregnancy. Gravid refers to pregnancy. So here you can understand it is simple vomiting means emesis gravidarum. If it is something which is severe, then it is called as hyper emesis gravidarum. Okay. Also here written as pernicious vomiting. So basically understand that in early pregnancy you can have simple vomiting or hyperemesis gravidarum. Coming to late pregnancy, guys, they are talking about some vomiting that is related to pregnancy. So it can be happening that it is a continuation of all the simple vomiting itself, or there can be preeclampsia, acute fulminating preeclampsia, which is causing the vomiting. Now let us look at what the definition of this hyperemesis gravidarum is. Excessive vomiting of pregnancy. So there is vomiting in pregnancy, yes. Excessive of that is hyperemesis gravidarum. Is there a volume of it saying how many times you have to vomit? Nothing like that. It is incapacitating the day-to-day activities, or it is deteriorating the health of the mother. Then only you call it as hyperemesis gravidarum. Okay. So there is incapacitation or deterioration of the health. So nothing specific here, but you have to say that is excessive vomiting in such a way that it is incapacitating or deteriorating the health of the mother, then only it is hyperemesis gravidarum. Remember, this should happen only in pregnancy, then only you will use this gravidarum terms. If you are vomiting every day lots, then it is hyperemesis, but as you are not pregnant, it is not gravidarum, hyperemesis gravidarum. Okay. Now, if you see a pregnant woman who's vomiting too much, don't go and tell, oh, you have hyperemesis gravidarum. No. What are the differentials for hyperemesis gravidarum? Maybe she has an intestinal infection. Maybe she has an intestinal obstruction. Maybe she has some hepatitis, ketoacidosis of diabetes. Maybe she has pyelonephritis. So they're blaming every organ in the body. So they're blaming pyelonephritis, they're blaming the kidney, they're blaming probably the liver hepatitis, intestinal infection, intestinal obstruction. Then stomach, they're saying about peptic ulcer, probably she has appendicitis, probably she has cholecystitis, probably she has pancreatitis, something like gynecology, probably there is twisted ovarian tumor, and then they're talking about probably there is a fibroid here in the uterus, right? Fibroid, degeneration of fibroid, probably there is hiatus hernia. So many causes they are talking about for hyperemesis gravidarum, because see, hyperemesis means you're vomiting a lot, can be any GI kind of issue, right? So they're blaming the entire abdomen, whatever organs are there, everything you'll have to write in differential, remember. Okay. Then what are the complications? What happens if you're vomiting? Is it a big issue? Yes, it is. So these are the complications that you will have to know about, guys. For the mother, she can go into neurological complications. They have put this first. Understand, neurological complications she can go into. And what are those encephalopathies? See, Wernicke's encephalopathy. See, it is there in beriberi due to thiamine deficiency, right? Wernicke's encephalopathy. That's why for pregnant women they give thiamine. How much do they give? 1.1 milligram per day is the normal, plus they will add 0.2 milligram per day, right? You've seen that in the diet. Then pontine myelinolysis. What is this pontine? Something to do with the pons, is it? Anyways, this doesn't look good to me. Lysis, whenever this lysis word, and what is it? Myelinolysis. Doesn't sound like a good thing at all. Okay, then coming to peripheral neuritis, where is that? Okay, then all these are neurological, is it? Okay, wait. All these are neurological. Wernicke's encephalopathy, pontine myelinolysis, peripheral neuritis, Korsakoff's psychosis. This you have already seen in thiamine deficiency. Basically, Korsakoff's psychosis is the memory loss, and they will try to confabulation. They try to make up stories about those memory loss periods. Wernicke encephalopathy, where you have even ophthalmoplegia, nystagmus, etc. Right? Then coming to stress ulcer, there can be stress ulcers in the stomach. Guys, we are looking at the maternal complications of hyperemesis. So you can see here the photo of the fetus is so small. Fetus is very small, because in early pregnancy only this happens. That's why we found the fetus which is really small. So this is all is happening to the mother. Ulcers in the stomach. Esophageal tear. Now this is very bad, right? Mallory-Weiss syndrome. What is this Mallory-Weiss syndrome, guys? Let's see this. Mallory-Weiss syndrome, basically tear or laceration in the mucous membrane. Mallory-Weiss syndrome. Everything is tearing. I don't know why here there's everything lysis and then tear here. Ulcer is also kind of a drilling kind of a thing, stress ulcer in the stomach. Then these people can have hepatic failure. I don't like this at all. Convulsions and coma. Again, I don't like this. They are losing a lot of water, is it? Hyperemesis. They are having dehydration. Then hypoprothrombinemia due to vitamin K deficiency. I'm thinking this is linked more to the liver, is it? Renal failure. What is not suffering here? Liver is suffering. Brain, kidney, stomach, esophagus, everything. Okay. Standard things you'll write, guys. Liver, kidney. Okay. Then, what happens to the fetus? Fetus is so small. See here? In Hyper Emesis Gravidarum. But it is not affected that much. Okay. So, let's say it is unaffected. Fetus is unaffected. Give us a green. It is unaffected. Okay. What are we talking about, guys? Hyper Emesis Gravidarum. Okay. Hyper Emesis Gravidarum is rare, guys, and that too something that cannot be managed at all. That really doesn't happen. It is rare, and especially the intractable Hyper Emesis Gravidarum is rare. Okay. You can treat it, and you don't have to terminate your pregnancy or anything. Okay. Now, where are we, people? Let us now look at the causes. Okay. Causes of this vomiting in pregnancy. What are we going to look at? Causes of vomiting in pregnancy itself. Let's look at. Let's start with simple vomiting also. Why does it happen? So basically, it is a sign of pregnancy. You know that in signs of pregnancy you have seen, right? It is actually, where is it? It's also called as morning sickness. You know this one. It is a sign of pregnancy or symptom. Yeah, symptom of pregnancy. Fine. Basically, they are blaming this high level of serum human chorionic gonadotropin, that's HCG, because HCG is more. That is why all this is happening, and because of estrogen and altered immunological status is the responsible. And without treatment, this will go away by 12th to 14th week, okay? And it will not incapacitate the person, or the person's health will not deteriorate. They will not go into dehydration, etc. So that is what is simple vomiting, okay? So how will you treat a simple vomiting? Basically, you'll tell them to eat small meals, right? And then you should tell them to eat a dry biscuit or a dry toast or biscuit. Biscuits you should eat. Nothing called as dry biscuit, I think, yeah. Dry toast or biscuit they should eat. They should take lot of vitamin B1. Thiamine supplementation they are telling. Okay, they should take thiamine. Didn't know that's so important actually. But still, if all this, etc. doesn't help, thiamine or small meals, etc. doesn't work, then you can give them anti-emetic drugs like TriFluoperazine. Okay? Fluperazine. You can give, okay, anti-emetic drugs you can give so that they will not feel like vomiting. So simple, right? Promethazine, Ondansetron also they're talking about. All these are also anti-emetics only, right? All this you can give. You'll tell them to drink juice, take plenty of fluids and fruit juice. Wow! Can they take plenty of fluids and fruit juice? Won't they vomit? Okay. So somewhere we saw this small meals like that, okay? Small frequent meals. So basically, this is about simple vomiting. So what did you gain in this slide? Basically, you should understand that it is why is the vomiting happening? High level of serum human chorionic gonadotropin. If you don't write this word in this exam, in this question, you will not get marks. Beta HCG. Because of that, this only is helping you determine that whether you're pregnant or not also, right? Estrogen also you blame always a little here and there. You will blame estrogen, remember? So you blame some estrogen. Blame some human chorionic gonadotropin hormones, and then some altered immunological states are considered for the initiation, okay? Then what happens? Because of a neurogenic factor, it gets aggravated. Because, you know, that feeling of nausea, etc. So it gets aggravated because of neurogenic factor. So it's always nice to change your environment, take a change, take a break, etc. Run away from the smells at home, eat cucumber, do not look down always onto your phone because that also makes you feel like vomiting, etc., etc. Guys, now let us move on to Hyper Emesis Gravidarum. Let's understand what exactly is happening here. So basically, severe vomiting, the incapacitating the person, deteriorating her health. So what happens? She's vomiting a lot. So what will happen? She can have dehydration. First, let's write dehydration. Dehydration. She's losing HCl from the stomach, because stomach is making acids and she's vomiting it out. So she can go into alkalosis. And then she's starving because she's not able to eat. So she can go into acidosis. There will be electrolyte imbalance. What will be there? Hypokalemia. She has less potassium. Less potassium. Correct, right? Weight loss. Weight loss is okay only in first trimester. Otherwise, weight loss is a bad thing in pregnancy. You should never try to lose weight. But if you are losing weight in the first trimester, it can happen because of hyperemesis gravidarum. Okay. So this is what happens. And when they talk about etiology, guys, they are telling about some generic stuff. Okay. Like if these people had some history of motion sickness and, they can't take, they were vomiting a lot before also. Motion sickness, they kind of go in a car and they start vomiting, or they go travel by bus and they start vomiting. So maybe these kind of people can have hyperemesis, or they are younger in age, or they are having it in the first pregnancy. They have low body mass. That is strange, right? They're low body mass they have. So, and they probably familial also. Okay, it could be hereditary. Mother has, a daughter has now, kind of a thing. It is seen in younger age. Okay, younger age women, early first pregnancy, they're telling. Okay, if they had a history of morning sickness, migraine, then what else? And usually this happens only in first trimester. Then it settles down from 12 to 14 weeks, we told you. Okay. So just write all this. And it could be a molar pregnancy. Okay. That you should be very careful of. So molar pregnancy means, two sperms attacking the same ovum, or an empty ovum being attacked by sperms. So all that you know, right? Hydatidiform moles. And they are telling about some psychological factor here. They are saying that if it is an illegitimate pregnancy, there will be less incidence of hyperemesis gravidarum. They are trying to hide it or what? And they hide the hyperemesis also. And one more point the textbook says is these women will also have some transient hyperthyroidism, okay? Because of because they are observing that these women who have hyperemesis gravidarum could have a transient, that means at that time, or a temporary type of hyperthyroidism they can have. Okay. Now let us see what the theories are there to explain all these crazy vomiting episodes. Okay. So it could be hormonal theory. That means because of what? HCG. You already saw that. So higher biological activity of HCG. And then we told you about estrogen. Just blame some estrogen, blame some progesterone, blame some HCG. Your whole obstetrics will be over, and gynecology also. Right? Always blame these people. Progesterone. Blame these people, guys. Some other details if you want. Remember, progesterone, it will relax the cardiac sphincter of the stomach, and the stomach will be retaining a lot of fluids. Okay, because there is impaired gastric motility, the stomach will be having a lot of gastric fluids, and the cardiac sphincter of the stomach is relaxed. So what will happen? These people will vomit it out. That's all. Okay, so all this about the hormones you blame. Remember, the first thing that you will blame is the beta HCG. If you don't blame beta HCG, hyperemesis gravidarum is not useful, right? You have to blame. And especially this HCG will be more in, much more in molar pregnancy. So you should be very careful to rule out a molar pregnancy. Psychogenic. So once this nausea begins, so this neurogenic element is there. So like we told you, if you just ask the patient to change their home surroundings, etc., they might have a less emesis. Okay. Then diet, they are probably low. Okay, that's why they told low body mass index, body mass these people might have. So that is one of the theories, right? So if these people are having no dinner, then it can happen. So if they are not eating in the night before, no dinner, I will just write it like this. Vitamin deficiency. So all this can lead to hyperemesis gravidarum. What type of vitamin deficiency? They are talking about deficiency of vitamin B6 and B1. That is pyridoxine and thiamine. That's why you should give pyridoxine and thiamine to these people, looks like. Okay. And protein deficiency also. Allergic immunological basis. So some kind of allergic reaction these people are having, is it? And one more, they said decreased gastric motility. Decreased, how is that a theory? Decreased gastric motility is another point that the textbook says, okay, for a theory. Look at this, whatever is the cause, finally what will happen, these people will vomit, then there is starvation, there is ketoacidosis, again they'll vomit. So it's a vicious cycle of vomiting. So what happens because of all the vomiting? We already told you, liver gets affected, liver enzymes are elevated, centrilobular fatty infiltration without necrosis, renal failure, kidneys, fatty changes in the cells, right, of first convoluted tubule, which may be related to acidosis. Then what will happen to brain? We told you that all these encephalopathy, myelinolysis, peripheral neuritis, Korsakoff's, psychosis, all this neurologic complications. Basically in the brain you can see small hemorrhages in the hypothalamic region. So Wernicke's encephalopathy, etc. Okay. So these are the complications. What and all is affected? Heart, liver, heart also. They can have a small heart. Okay. Brain, heart, liver, everything affected. When you look at these people's tongue, no guys, it will be dry coated tongue, okay, dry coated tongue, sunken eyes, acetone smell in breath, right, that ketosis, acetone smell in breath, tachycardia, hypotension, rise in temperature, jaundice, but this and all is, nowadays all this is rare, okay, so such severe symptoms and all are not there. They told you the hyperemesis gravidarum itself is reducing, and when you manage it, it completely is manageable. So, all these things are very rare, okay. But features of dehydration and ketoacidosis, you will see this, you have to tell in the exam, right? See guys, for these people, what and all you'll do an ultrasound to check what type of pregnancy it is, etc. You will do urine analysis, you want to check the quantity of the urine, you will check if it is any infection also, you should know, right? Then biochemical, you can check for glucose, sodium, potassium, chloride, all that. Thyroid, you will check for TSH, T3, T4, because you know, right, they can have a transient hyperthyroidism. For severe cases, you can do ECG and eye exam, okay? So, all this, did you understand? How will you treat now? Let's come to treatment. Hello people, now we are looking at treatment, okay, focus here, we are looking at the treatment of hyperemesis gravidarum, not simple vomiting. Simple vomiting we have already finished if you remember. So now in hyperemesis gravidarum, you will hospitalize the person. Why? Because this is a emesis to the amount that this person is incapacitated from day-to-day activities and their health is deteriorating. So you will hospitalize, right? So you know what and all tests you are doing for these people, ultrasound examination of the abdomen, pregnancy, all that you saw, urine examination, biochemical, you will do thyroid test, eye exam, ECG also you will check because they have electrolyte imbalance and they can have ECG variations because of the electrolyte imbalance, is it? So all that you will check, and you will also eliminate all the other causes that you saw in the differentials. Then you will give them fluids like dextrose ringer. You want to maintain the hydration, electrolyte balance, etc. Total you will give, they're saying around 3 liter. Half of it, that is 1.5 liter dextrose, 5% dextrose, and the remaining half ringers, okay. Then coming to antiemetics, they're talking about Phenergan. This is the trade name, looks like. The actual chemical name you should know, pharmacology. Promethazine. Then ProChlorPerazine. Guys understand, Promethazine, ProChlorPerazine, TriFluPromazine, Metaclopramide, Ondansetron. Very difficult for you to remember these names, I think. At least azine is same. Okay. Antiemetic drugs. So because she will not feel like vomiting if you give this. And she won't vomit. Say the names. 2 pros are there. Azine. Methazine, chlorperazine, TriFluPromazine. This sounds like prom, right? Okay. Then you will give vitamin thiamine, that is B1, 100 mg. And nursing care, sympathetic but firm handling. What does this mean? You should be sympathetic with the person but handle firm. You have to maintain chart, input, output, acetone output, etc. Okay, because they can have ketosis. So this is all is the treatment for hyperemesis gravidarum. Now let's take a recap, guys. Hyperemesis gravidarum, we are looking at obstetrics. Basically, vomiting in pregnancy can happen in early pregnancy or late pregnancy. Early pregnancy, it is simple vomiting, morning sickness, though it is not at all in the morning, it can be throughout the day. It is called as emesis gravidarum because of elevated beta HCG. Whenever this becomes, this can incapacitate the person or deteriorate the health of the person by dehydration, etc. Then it goes to hyperemesis gravidarum, that is also called as pernicious vomiting. In late pregnancy, there can be because of the same causes can continue, or there can be preeclampsia, acute fulminating preeclampsia, which can be caused in late pregnancy. Okay, so basically how do you say what Hyper Emesis Gravidarum is? Excessive vomiting in pregnancy, remember, don't forget the word pregnancy, incapacitating day-to-day activities or deteriorating the health of the mother is Hyper Emesis Gravidarum. Okay, there is nothing here to suggest that how many times she has to vomit or how much volume, remember that. Then if a pregnant woman is vomiting a lot, please don't think that it is Hyper Emesis Gravidarum. You have to rule out intestinal infection, hepatitis, urinary tract infection, ketoacidosis of diabetes, pyelonephritis, uremia, appendicitis, peptic ulcer, intestinal obstruction, cholecystitis, pancreatitis, twisted ovarian tumor, fibroid, red degeneration of fibroid, hiatus hernia. All this you will have to rule out. Then coming to some generic thing, it is actually a rare phenomena nowadays, and you can easily manage it, okay, with all these medications. Now, simple vomiting, we told you, like, it's not just morning sickness, it occurs throughout the day because of raised human chorionic gonadotropin, beta-HCG, estrogen, etc. It can happen. It is a symptom of pregnancy. How will you treat a simple vomiting? You can give supplementation of vitamin B1, anti-emetic drugs like same thing, TriFluoperazine, etc., Promethazine, Ondansetron, similar drugs like the Hyper Emesis Gravidarum, actually. Now, Hyper Emesis Gravidarum, what will be there? There will be increased frequency of this vomiting with retching. Okay, retching you have to remember. They have said specifically with retching. So this person will go into dehydration. They are losing so much of water, isn't it? Now, they can have decreased urine output. They will lose a lot of acid from the stomach. They can go into alkalosis. Then they'll starve. So they can have acidosis. They will have acetone breath, right? They can have hypoglycemia. They can have electrolyte imbalance like hypokalemia, less sodium, less chloride. They can also be weight loss, right? And hepatic dysfunction results in ketosis, right? Because of hepatic dysfunction, there is ketosis, there is increase in the blood urea, uric acid. The patient will suffer from hypoglycemia, hypoproteinemia, hypervitaminosis, hypovitaminosis. They'll have epigastric pain, constipation, etc. Look at the signs they will have, that they will have a dry coated tongue, sunken eyes, all dehydration, acetone smell in breath. Basically, they'll have dehydration and ketoacidosis. In severe cases, very, very severe, which is very rare, they can have tachycardia, hypotension, rise in temperature may be noticed, and jaundice because of hepatitis, isn't it? Hypotension, they have lost so much of water, high dehydration. Okay. But if there is fever, etc., you will have to rule out the infections, remember. Then coming to the complications, if you thought it is just this much, no guys, it's not just dehydration, ketoacidosis, etc. The complications of mother can be so many, like hepatic failure, right? The liver is getting affected, jaundice, liver enzymes are elevated, there can be fatty, centrilobular fat, etc., right? Fat infiltration, they are saying. Then, hold on, without necrosis, okay? That is the description of the hepatic failure. Then renal failure, right? In the first convoluted tubule, they are saying fatty change in the cells. Then they are saying there can be problem with the nerves. There can be Wernicke's encephalopathy, pontine myelinolysis, peripheral neuritis. There can be Korsakoff psychosis where they will be having memory issues, right? Memory issues can be there. Wernicke's encephalopathy will be having some ophthalmoplegia and all. Ophthalmoplegia. You have studied all this in beriberi, isn't it? Vitamin B1 deficiency, thiamine deficiency. Then coming to the brain, there can be small hemorrhages in the hypothalamic region. Okay. Then coming to stomach, there can be stress ulcers, esophageal tear, that is Mallory-Weiss syndrome. Do not forget this. Mallory-Weiss syndrome, esophageal tear, convulsions, coma. I think this should go something after, I would put this after the neurologic complications, isn't it? Then hypoprothrombinemia, renal failure, etc., small heart. Now, what is happening to the fetus? Fetus is still very small because this is early pregnancy. We are telling you Hyper Emesis Gravidarum, but the fetus is usually unaffected. Okay, it can have low birth weight though. Now, coming to the cause, why does it happen? It usually is seen in the first trimester and the first pregnancy of the woman. Family history can be there. Then younger age women, low body in mass if she has, right, and if she's skipping meals in the night, they are saying this can happen. History of motion sickness if she has had before this pregnancy, you can understand. History of motion sickness, migraine, right, if she has had all these stuff before the pregnancy itself, migraine. This is very sensitive, you can say, right, migraine. Look at this. Younger age. Usually anything in gynecology and obstetrics blames the increased maternal age for everything. You know, they easily love to blame the woman. Here they're blaming the younger woman for a change. Could be a molar pregnancy, guys. So you should, molar pregnancy will have excess beta HCG, so they can have more vomiting. So if there is excess vomiting in pregnancy, it can be the pregnancy is a molar pregnancy. Okay. The hyperthyroidism. These people can have a transient hyperthyroidism. Remember what molar pregnancy is, guys? It is a abnormal pregnancy. Okay. So it is not a normal pregnancy. Here, anyways, the fetus will not survive. In fact, at times there will be no fetus, only grape-like clusters will be there in the uterus. Now coming to the hyperemesis gravidarum theory, why does this happen? We already told you, increase beta HCG and blame some other hormones along with beta HCG, blame estrogen, blame progesterone. Progesterone actually will relax the cardiac sphincter of the stomach, and there is retention of gastric fluid in the stomach, right? And there will be due to impaired gastric motility, there will be more fluid in the stomach, and the sphincter is relaxed, so obviously she'll start vomiting. Psychogenic, you should understand that if you change her place or you distract, probably she will be better. So there is some neurogenic link. And diet, if she doesn't eat dinner in the previous night, if she has not eaten, or if there is vitamin deficiency in her like B6, B1, that can happen if she has allergy, immunological basis. We told you that if she has history of these motion sickness, migraine, etc., decreased gastric motility if she has had. Look at this vicious cycle is that you vomit. Because of vomiting, you will have starvation. Because of starvation, you will have ketoacidosis. That will again make you vomit. Okay. So now, what are the scans tests you will do for these people? You will do an ultrasound to check the pregnancy, what type of pregnancy, etc., etc. Urine, you will check for the quantity, infection, acetone bodies, etc. Biochemical, you will check for glucose, sodium, potassium, chlorine. Thyroid, you will check because they can have transient hyperthyroidism. ECG eye examination you can do for severe cases, because we told you Wernicke's encephalopathy, they can have nystagmus, ophthalmoplegia, etc., right? Then coming to the treatment of hyperemesis gravidarum, we are not talking about simple vomiting here. Hyperemesis gravidarum, how will you treat? You will have to hospitalize the person, you will have to do all those investigations. Alright, then you will have to give fluids, you have to give 3 liter, around half of it is 5% dextrose, remaining half is ringers. Antiemetics you can give like Promethazine, that is called as Phenergan, ProChlorPerazine, I think this one is stemetil, right? Stemetil that they have mentioned in the textbook. Then TriFluPromazine, Metaclopramide, Ondansetron. Okay, let's just make this black. Then vitamins you will give thiamine, that is B1. Thiamine is nothing but B1. Nursing care should be sympathetic but firm. Maintain the charts of progress, input, output, acetone, output, etc. Okay. So that completes this topic of hyperemesis gravidarum, guys. So you have understood that hyper is more, emesis is vomiting, gravidarum is during pregnancy. Okay. That's all for now, guys. Meet you in the next video. Bye bye.